We're going to kick it off tonight with mental health services and supports in the Ames Community School District, and I'm pleased to introduce Nicole Patton. She's the Associate Principal at the Ames High School, and she'll kick it off, and then we'll transition into Iowa State. Oh, before I move on, I want to recognize we have Jacob Ludwig here. Jacob, raise your hand. He is the President of ISU Student Government, and I forgot your name. Charlotte, right? And she's your boss, is that right, Jacob, or how's that work? Something like that, right? No, anyway, she, with wellness and student government. So anyway, great partnership with, hear that tonight from Iowa State, but also with student government, so we're glad you're here too. So with that, Nicole, we'll let you get us started.
Like you said, I'm Nicole Patton. I'm one of the associate principals at Ames High School. We have 3 of them now, which is fantastic. And I'm going to talk more about what the high school has to offer for mental health than what the district does, because I do not know a lot what's going on in the elementary school. I see Arch here. We've used you guys. Thank you so much. You're fantastic. It's been a blessing, really, having you guys. So I just have basically 3 slides that I was just going to walk through and share with you what we do and what we have. We actually have started an AHS mental health and wellness clinic. It started out last year as I had some people approach me that said, hey, what can we do for you? What does Ames High need? And I said, I need counselors. I need people for my kids to go and talk to. We know that going into counseling, it takes months to get into it, and my students need help, and they need help now. And so I also need crisis interventions. And so what happened is we were blessed enough to actually have Cornerstone step up counseling. And so they were coming last year about 5 days a week. And then we also had some crisis hours with them. And through that, we kind of have gotten some feedback back that of course, everybody does not want to go to Cornerstone Counseling, and I understand that, but they were who helped me and who helped me for free, right? So, did I just hit, okay. And so this year what we did, did I hit something? I think I'm on, okay. So this year what we did is we have YSS, SIPS, I have an independent counselor coming in, and then also Cornerstone. So each day is a different counseling service to come in. And so we are in the middle. I just actually talked to Amy, who's in charge of our communications, and I said, hey, do we have our website going up right now? They are creating a website so the students are able to see the logos. They click on the logo, they'll go to a Google form, kids can fill it out, it's their choice of what they want to go to. Kids are being seen within 3 days of needing help. So that was a huge gift. They take, one of the things was, well, what do we do if we don't have insurance, right? So we found out they do take Medicare, Medicaid, and then we also still have the scholarship fund. We do have an outside donor paying for students who don't have any of the above but need services. So there is a scholarship for students who just need help and who can't pay for that, and they can go to any counselor they want to with that, because that is the choice of the student. We feel like that's super important to have that. So that is what we're doing now. Talked about the kids paying. The one thing about this is when we did have students going to their counselors, they were missing a lot of school. So last year, our parking lot was quite a long ways from the building. Not so much this year, but and so we really felt like it was important to have that. So when we actually built the new building, we have a room for the counselors to come. They've decorated it. They've made it their own. They've made it their own space. There's a great couch, blankets, fidget toys, chocolate, all the kind of stuff that the kids would want, and that you would see in a normal, typical counseling center. And then the counselors get together, and then they decide what they need and what they want. And we kind of go from there. So it's been a huge blessing. Our students love it. We've had just a great response with the kids, and the parents really seem to like that too. I do really appreciate having the diversity on every day. So basically YSS comes in Monday, Tuesday, SIPS comes in Wednesday. Like I said, Thursday is that independent, and Friday is Cornerstone. So we have tiers of support. of course, our tiers of support, we always want to start with that classroom teacher. Our teachers are getting better at telling us what they're seeing within our students. If they're struggling, if there's an attendance issue, we can have those open conversations then with the students. We really feel like that tier 1 begins with the teachers. Our nurse this year, we have a new nurse. She's fantastic. She has created a quiet room. She has a huge leather chair in there. It's really cozy. She's put in a fish tank, a really cozy rug that kids actually like to sit on better than the leather chair sometimes. But just a space for them to call their own, be safe, and if they want somebody to go in there and talk to them, they can. And if they choose not to, it's just a safe space for them to go, right? For when either they're having anxiety or whatever they might need that for, and then she goes in and checks in on them. One thing we also have too this year is we have a school psychiatrist that we hired. She's my crisis girl, so anytime that there is a crisis that somebody needs help right now, in that moment, she is the person we go to. She will walk them sometimes to the nurse quiet room, but a lot of times they are just in her room working with her, or she will go into the counselor's room if they are, if the counseling room is available. But she has been a godsend. She's licensed, and it's been great to have her. She's also a teacher in the building, so the kids are getting to know her and feel more welcome with her, and she's always out at lunch. And it is so funny, like 3 kids will find her every lunch period. And we're like, you don't have lunch duty ever. And she's like, I know. But it's just those kids are grabbing her, right? But it's a good thing to have a safe person. We also have our, I would say, a higher level in the tiers is our TLC classroom. So a lot of those students are either students that are coming from hospitals, needing to go to hospitals, or in any kind of other outpatient services, or where we're super concerned about them, where they have really are having a difficult time. That teacher is helping them learn about tap outs. They work on strategies for coping when anxiety attacks happen. It's also just a really safe space for them to have. And then we also have an SFA that works closely with our TLC teacher and then our psychiatrist. And what's really cool is that they're building a bond now that they can come together, talk about students, figure out where that student needs to go, what's going to be best for that student, and then we have more of a proper channel than we've had before. So it's been really good that way. Future hopes. So I got to see, I call her Zoe, it's not, so it's Zosha. She came to the high school today, so I was pretty excited. But I'm actually working on trying to get a therapy dog at the high school. She's going to do all the research, and then we're going to present it. We have some backing of some of the district office, and they have some questions. So, of course, we're going to answer those. But it would be really beneficial if we're going to say we care about mental health, about our students, and we know how what the benefits are of having a social, emotional, or a therapy dog in our school. Let's do it then. Let's just not go halfway on if we really truly believe in mental health. So we are looking at getting a therapy dog. We're going to take all those steps. I've turned in all the different schools that have therapy dogs, so it's been fun. And then also we are working on getting alternative school. I know a lot of you have probably heard that we bought Beloit. We are not going to call it Beloit. Beloit has a stigma. We don't need that stigma on the students. That's super important, 1. 2, the alternative school is not for bad kids, and we cannot stress that enough. I don't, and I don't think anybody else wants that to be known as where we put kids when we can't handle them. I have students who cannot walk into the school without having an anxiety attack. I have kids who cannot be in a classroom with more than 10 students without not being able to function. I have kids who come into my office and cry. I have kids who cannot sit in the lunchroom that sit in the corner of my office during the day. They need another space. This space is going to be able to be available for them. So it's really important that we have that alternative school. And so I just kind of wanted to get that message out that when we do alternative school, it's for all kids, and it's for the kids who need a different placement, not because of a behavior. It could be a behavior, right? But it's also because that child is struggling socially, emotionally, whatever, and they do have that other option. We can't say that this one school, it's beautiful, and we thank Ames for it over and over and over, but not one building is going to fit all kids, and we need to realize that as an Ames community. So that's my presentation right now. That's where we're at Ames, but we're learning, we're growing, and we're just trying to get better. And I think the bottom line is that we want our kids to know that we love them, that we care for them, and we know not one size fits all.
Thanks, Nicole. Second presenter is going to be Aaron Baldwin and Brian Vanderheiden, and they are with the ISU Health and Wellness department, I guess, or whatever you want to call it. And as you all aware, almost half of our residents in Ames are Iowa State students, and we know that mental health is a really important aspect, not only to them, but also to student government and administration as well, too. So we're going to ask them to talk about data and on-campus resources.
Hi, everyone. Good evening. Brian and I are very excited to be here today. So we wanted to share an overview of what resources are available on campus for our students, also share some data as we think about how do we look at what the data is telling us to decide how to invest in resources and change our strategies, and then talk a little bit about the strategy that we're taking on campus that we hope that also can tie into the community. So starting first here, this is just our impact statement. So it's a lot of things on one slide, but one quick overview of all the different services that we have on campus. We're very fortunate to have a lot of services available for our students on campus. We have our Recreation Services Department, Student Wellness that Brian will talk about, Student Counseling Services, and then our Thielen Student Health Center. And really our goal is for all four of those departments to work together to focus on holistic well-being for our students. When we think about mental health, that means something different to each of our students. So for one person, it might be getting involved in recreation services and doing intramurals to find community and friendship and belonging there. For someone else, it might be working with one of Brian's peer wellness educators and getting that peer-to-peer interaction with resources. Working with a counselor at Student Counseling Services, or it might be seeing a provider at our health center to look at medication options to support mental health. So we're really proud last year that we engaged with over 78% of our student body. We're working to make that 100%, so we'll keep working on that, and had over 844,000 interactions. So really proud of those things and proud of the great professionals that we work with every day on campus. So we also wanted to share a little bit of our mental health data on campus. So we've been going through a comprehensive needs assessment that Brian and I are going to talk about, and wanted to share a little bit of data. So one of the things that we participate in every other year is the American College Health Assessment. This is a national survey. It's the largest one of college students and looking at their health behaviors, their habits, and their perceptions. So again, we participate every other year. We've hyperlinked the executive summaries in here, and we're going to talk a little bit about some of the themes that we saw from these things. We also participate in the Healthy Minds survey. That's also a well-known college health assessment at looking at student mental health, and then our needs assessment that Brian will talk about as well. So looking first at the National College Health Assessment, this gives you just a snapshot of where all of our students, so whether you're talking about our undergraduate or graduate students, kind of how they compare to thousands of other college students across the country. So as you can see there, our students are less likely to be food insecure. They're more likely to report a sense of belonging with the university, more likely to get between 7 and 9 hours of sleep, less likely to have ever used cannabis, and are less likely to report high levels of overall stress. In the middle section there, our students have similar levels of positive screening for loneliness, similar levels of positive screening for suicide risk, similar scores for psychological well-being, and similar levels of tobacco or nicotine delivery product use. Our students are less likely to describe their health as very good or excellent, more likely to use alcohol within the last 3 months, less likely to say that Iowa State is a place where we look out for each other, less likely to have received the flu vaccine, and less likely to report feeling very safe on campus. So those are kind of high overarching themes that we're working on addressing. Next, we have our Healthy Minds study. We did this actually pre-COVID, so we're looking to do that again now that we're kind of moving out of the pandemic, so we can look and see, because we anticipate when we look at these scores again that they may be significantly impacted based on what we've seen here. So that you can see about 14% of our students screen positive for major depression, anxiety disorder, around 23% of our students, suicidal ideation in the past year, around 13% of students. About 24% of our students are on psychiatric medications, and about 22% have used mental health or therapy counseling in the past year. So just picking out a couple things there, but you can see the trends that we saw in the Healthy Mind Survey. And then I'm going to turn over to Brian to tell you about our focus group summary.
Thanks, Erin. So as part of our broader needs assessment, part of that was looking at some of our quantitative data that we had available. So that was what Erin was sharing, where we did not have a lot of data, was in more of the qualitative data. So we wanted to do a pretty robust focus group study. So in this last spring, we had a graduate student who's actually now working at the CDC, which is great, Dr. Laura Triplett, that led all of our focus group studies, so helped us with designing the methodology, the implementation, and then did all of the transcribing, coding, and kind of follow-up results and reporting connected to that. So like I said, it was a large study. We had a very large sample, 201 students. We had 27 focus groups. They were all 90 minutes long. Students that we recruited, we had pretty intentional groups to really kind of get a cross-section of our entire community. So we had groups specific for students of color, first-generation students, graduate professional students, our queer and trans students, students of color, students with disabilities, militarily affiliated students, et cetera. So we had a wide range of focus groups that we held. We usually did 2 to 3 per identity to really kind of get a cross-section of our overall community. And just kind of really high level, some of the findings that we pulled from that is students talked a lot about kind of overall general well-being and basic needs. So really kind of highlighting the importance of having good well-being essentially to their success in higher education and for learning. Talked a lot connected to around accessibility to basic needs support. We are seeing a growing need, particularly when we think about financial need, food insecurity, et cetera. So that was something that students had talked about a lot, and continuing to get access and availability to services and resources to help with that. Also a lot of conversation around sleep. Students are very busy, and getting a really good kind of consistent sleep pattern overall is just something that they identified as being really challenging. And we know from research too how important sleep is to learning. So that was something that students had talked about. When it came to mental health, students had talked a lot about stigma on campus, particularly connected to peers. So thinking about how their peers are going to think of them if they need help in terms of kind of seeking. So when we think about help seeking, so getting connected to support, a lot of kind of concern and fear around that. And also the need to really enhance awareness of resources. So thinking about how are we continuing to promote and get students connected to that, and really needing to do a lot more work in that area. Students also talked a lot too about when we think about faculty and staff and continued education and opportunities for faculty and staff to really enhance not only their own knowledge about well-being, but how to help think about strategies that they can infuse within the classroom, within the work environment, and also to help for students that might come to them, or for students in distress, how to get them connected to support on campus. And then also the accessibility to mental health services. So thinking about our students are extremely busy, so thinking about how are we having options to help increase access to students and try to limit as many barriers as possible to students getting connected. When we think about power-based personal violence, so when we say power-based personal violence, thinking about things like sexual assault, stalking, dating violence. Students had talked about the negative experience and impact that can have on their overall experience, particularly when we think academically, socially, professionally, really impacts students in their entire lives when we think about students who are survivors of any type of power-based personal violence, and really the need to expand prevention efforts and kind of proactive ongoing communication to really help with transparency to the community or to the broader community, but also thinking about how are we proactively working as a campus community to continue to work to create a culture that does not tolerate or support power-based personal violence. And also thinking about ways that we can continue to modify the campus environment to help with increased levels of safety. And then finally, around substance use, this is not unique to Iowa State, but the students talked a lot about the normalization of substance use among their peers, particularly when you think about alcohol, cannabis, and then kind of broader tobacco products, vaping, et cetera. And then also, we do have a variety of support groups and resources on campus, but that of probably all of the resources were the kind of less known about. Students didn't really have an idea of a lot of those resources. So thinking about how we can continue to enhance our outreach and opportunities to get students connected to those supports. But students also talked a lot too about a desire for substance-free activities and things, and that the university does not really provide as much of that as they were wanting, particularly when we think about nights and weekends. So thinking about alternatives to going out, thinking about opportunities that the university can do to continue to connect students to opportunities that are looking for that. And as an example of that, we have all students, incoming students, complete an online alcohol training, and part of that includes a survey, so we get usually about 95% participation, so we get a really good response rate on that. And we usually have about like 40% of the incoming class that is looking specifically for substance-free opportunities. So it's a sizable amount when we think about the overall number of students that are really looking to get connected. So this wasn't like a surprising thing that we had found when students were talking about it. So some of the key insights, I talked a lot about these, so I won't go over them again. Pretty overwhelmingly, though, the students I talked about kind of across the board is really thinking about the ways that the university can be more proactive when we think about prevention and education. We do have a lot of really good support resources. Always have opportunities to enhance those. I think what was pretty clear from a lot of this was thinking about how are we continuing to enhance more of our prevention and health promotion infrastructure. That's a pretty key opportunity for us. So our needs assessment is really focusing specifically on that and thinking specifically how are we enhancing that broader infrastructure when it comes to prevention and health promotion. And then these are just some of the key recommendations like I had shared. Really kind of that emphasis around wellness and prevention was really key, as well as thinking about how we're reaching in terms of marketing communication to our students.
So just kind of summing all of that up, as we think about all of this data, all these resources, we're really trying to work towards, I guess, what Brian and I would classify as a public health approach at Iowa State. So thinking about how we work with all of our community partners, how we work on campus, and really change the culture to be one that's health promoting for everyone, especially as we think about mental health. So of course, not only just investing in resources, but also thinking about how do we change policies, how do we change our environment to be better supportive of well-being overall and mental health. So we'll look forward to sharing more things with everyone as we continue to work on that. Thank you.
Thank you. Next, we go into mental health first aid and applied suicide intervention skills training. Some of you may be aware that last year, Council authorized funding to help pay for mental health first aid training, and we had about 120 residents were trained last June, July, and August. And so that is also going to be available again going forward, and also ASSIST, which I'm going to learn more about tonight as well too. So I'm going to invite Julie and Kinsey, Carrie, and Amber up, and they're going to talk about these two topics, and I'll let them introduce themselves and the roles that they're playing.
I'm Julie Saxton. I'm the mental health advocate with the Ames Police Department, and I've been in this role for 8 years. I want to just give you some quick statistics from Ames PD. So last calendar year, we had 2,300 mental health calls for service. I responded to 1,500 of those. I should note that this last year, 20% of those calls for service were folks that were suicidal, that were experiencing suicidal ideations. That was up 10% in the last. So the first 7 years that I was in that position, it was 10%, so 20% those calls. We've had quite an influx of calls mental health related substance abuse, but again, significant folks that are suffering with suicidal ideations and wanting to end their life.
Hi everyone, I'm Kinsey Hauser, Mental Health Advocate Supervisor at ISUPD. Zosha is the dog wandering around. She's a therapy dog at the police department. So what my job is to provide support and resources for students, staff, and faculty on campus. And that looks like going on welfare checks with our officers. Sometimes it's bringing students into our office who are in crisis or who just need to hang out with the dog for a little bit and talk about how they can be connected to counseling or to student health or to community partners as well. So lots of education also that we do, which we'll talk about in just a little, and lots of fun things with the dogs as well. As you can imagine, they're just a really great tool to get people to actually come in and see me and to talk about what is going on.
Hi, I'm Susan Moore. I am an inpatient social worker at Mary Greeley here in town on behavioral health. I have been at Mary Greeley for about 8 years, worked in mental health for about 28 years. Prior to going to the hospital, I did residential care here in Story County for a program. Largely my role is to help patients plan for discharge, and everyone is unique and individual on the needs that they have. And it really varies on what it is we help with. If it's housing, getting them connected, making sure that they have appointments before they leave. A large part of my role too is to get that family connected and also to provide family members with education about mental health and substance use too. And then as we'll talk about, part of my job also is I teach mental health first aid with Julie and Kinsey and April, and have been doing a lot more community outreach things over the last year.
So a little bit about mental health first aid. This is great education for our community because as I was talking about those statistics, mental health is very prevalent. How do you guys know, let me ask you as a question, how many people will be diagnosed with a mental illness sometime in their lifetime? 1 in 4 folks will be diagnosed sometime in their life with a mental illness. So again, it's very prevalent. We really want to erase the stigma with regards to mental health. So mental health first aid is a great place to start for people who maybe just aren't comfortable having that conversation with somebody. How do you bring up asking somebody if they're okay? How do you talk to somebody that may be in crisis? And we cover all of that in mental health first aid. It is an 8-hour class. We usually take 2 days, so 4 hours each day. And the different topics that we discuss are depression, anxiety, anxiety attacks, paranoia, schizophrenia, bipolar disorder, schizoaffective disorder, substance abuse, and suicide. And again, the point of this is we want to educate everyone so that we're all equipped to be very comfortable talking about uncomfortable topics.
Yes, so we really enjoy having it not so much a class, but as a discussion. We get lots and lots of great feedback from people that they appreciate that, and that's really how we like to do the classes, more of a discussion. So I was trying to think of some numbers of what we've done over the last year that I had to present to the hospital board. I want to say at the time it was almost 100 Mary Greeley employees, and it's over that now, have taken the mental health first aid class since the summer maybe? Yeah, it hasn't quite been a full year. We also certified all of the Ames Fire Department last spring. All the firefighters are certified in mental health first aid. We've taught class to a section of staff at the public library. We've just really had a wide variety of great experiences teaching in the community, and really want to continue to do that and continue to go out and to reach more groups of people and to make this class available.
One thing that's really important to us, especially when teaching mental health first aid, like Susan said, it's a conversation or a discussion, but we're really relating it back to physical health. So we talk a lot about how, if you were to break your leg, you'd probably go and see the doctor. You probably wouldn't wait 10 years to go and get that looked at. So we do a lot of that, the comparisons between mental health and physical health, and just recognizing what those signs and symptoms look like for individuals, so that if you yourself are experiencing something, person, or maybe a friend or a coworker or family member, that you can reach out to them and feel comfortable.
These are some of the questions that we ask in the beginning of mental health first aid. How many of you in here know somebody who has been affected by mental illness? Raise your hand. How many of you are comfortable if you had to talk to somebody about their mental health, or if you had to have a conversation because you were worried about somebody? What are some negative terms that we still hear out in the community and society associated with mental health? Just yell it out.
Crazy.
Lazy.
What else?
Crazy.
Insane. Loony. Sick.
Did you say sick? Yep. What else? Nut job, right? What about violent? Do we hear that? Yeah, we hear violence associated with mental health, and what's really interesting to note is that most individuals that suffer from mental illness are victims of violent crime. They're typically not going to be violent, and that's something that, unfortunately, our social media does a terrible job of portraying, that people with mental health are violent, and that is simply just not the case. What are some other questions that we can ask everybody?
I always like the one, what percentage of people have mental health?
100.
They've got it. Sometimes it's like, oh, I don't know, like 15, I don't know, 20 maybe? But yes, so just really reinforcing that everyone has mental health, right? It could be good, it could be bad, it could be somewhere in between. It's just like physical health. It's just important that we take care of it.
So one of the things that we do during group that I like to share is, so if you think about, I gave a presentation online, and I had a video of a gentleman who was on the golf course, and of course he was lying down clutching his chest. And so what would you do if you saw a gentleman, or you passed someone on the golf course and they were lying down holding their chest? What would be your first instinct? So you'd want to render some kind of medical help or play through. Just kidding. So you'd want to render some kind of medical help. So let's think about a person that, let's say you are headed down, you're shopping at Target, you're bebopping along, you take a left-hand turn, you're like, oh no, there's someone crying. Someone's standing at the edge of the road of the aisle crying. So what do? How many of you would feel comfortable? How would you approach that person? What would you do? Would you back your cart up and head the other direction, hope they didn't see you? Like, what would you do? How would you handle that?
So I would walk over and say, either are you okay, or can I help you, or is there something wrong? I mean, I would approach. Okay, good.
Another thing we really promote is coworkers. So how many of you would feel comfortable having this conversation with a coworker? I see lots of hands. I think that's great. I think that that's sometimes an area that people are uncomfortable. They don't want to say the wrong thing. They don't know how to approach it. They think that maybe they'll make the situation worse if they say anything, so then they just don't say anything. So I'm glad to see lots of heads saying yes. I think that one can be a tricky one, especially when you see these people at work every single day. How do I handle this situation?
Something else that we want to make sure that you know is that this class is free. We want to make that free for our community. I think, I've been teaching for 7 years. I think I've got almost 700 people in this community that I have taught, and that's amazing. This class is just a really great introduction, again, to what is mental health, right? How can we help? One thing that we mention in this class is that we really are in a mental health crisis, and I don't know that it's going to get better anytime soon. And so this really is a community problem, and so this needs to be a community solution. So in order to do that, we have to really think about how can we communicate with one another better? How can we kind of go back to the way it was, right? And get to know our neighbors, get to know our coworkers, being vulnerable ourselves. We talk about that in this class, that we really are called to do that, that once we are vulnerable, other people are able to feel like they can be vulnerable. And then what happens is we connect and we build trust, right? And that's community. So statistically, For somebody that is mentally ill, to recovery, the process of recovery can be much quicker if you have a stronger support system, I mean, a big support system. So we talk about that a lot. So again, it goes back to community, goes back to all of us, that we really are responsible for educating ourselves and knowing, one, how to respond, and making sure that we let people know it's really okay not to be okay. I guess I will speak for Kinsey because we're really open about it. Both of us talk about, we have our own mental health diagnosis. I've had anxiety diagnosis for 20 years. I take medication. We talk about that. It's really not a big deal. One thing that the police department has done, and I'm very proud of our officers, that this past year, to promote mental health awareness and to destigmatize mental health, we had some of our officers go on camera and were filmed and talked about their mental health diagnosis and what their rank was. It does not matter because we know that mental health does not discriminate. Doesn't matter if you're rich, poor, educated, not educated, it affects all of us. So just, again, something that we want you guys to be aware of, that it takes a community to heal one another.
So real quick, I just wanted to add, so how do you reach us to teach? So really, it's quite simple. If you want to get one of our email addresses or all of them, we just get emails from people, like literally random emails that say, hey, I heard you teach mental health first aid. So when one of us gets that, if I got it, I would forward it to Julie and Kinsey in April, and then we would talk about a teaching team who was able to schedule and who was able to come out and teach. So it's really that simple. If you just get a hold of one of us, call, email. Email's actually easier because then we can send it to each other, and then we would figure out amongst the four of us who can come and teach the class.
Hi, everybody. My name's Carrie Lair. I'm a team lead for crisis services with Unity Point Arley-Ball Health. This is my 22nd year working in the crisis field.
I am Amber Christian. I am a sergeant with the Ames Police Department. I have been with the Ames Police Department for 12 years.
So we're going to talk to you today about ASSIST training, which the acronym stands for Applied Suicide Intervention Skills Training. And it's a bit similar, but very different from what mental health first aid is. ASSIST primarily focuses on suicide intervention, precipitating factors, stigmas, and how to have those conversations with people who are at risk and in the moment, and getting them to choose life instead of death. ASSIST is a very intense course. It's a 2-day, it's 16 hours, so the days are split up 8 hours on each day. It's a very heavy subject, but it is needed in the community. I think we pulled some statistics for the United States. The statistics for suicides in the United States for 2020, there was 47,000 suicides recorded in the United States in 2020, and 6,500 of them were age 10 to 18. In Ames, we've recognized there's a need for it in the community. We want to educate people. We want to get the word out and help, because this is designed for non-professionals. But again, it can be a trigger for people who have had that experience of somebody they care about, or have experienced a neighbor, somebody that has died by suicide. In Story County, our mobile crisis team from January 2020 to this January, I pulled the numbers, and we were looking at specifically suicidal ideation. And we responded to 435 suicidal ideation calls in that amount of time here. And that's not, we're not counting anxiety or depression, specifically suicidal ideation. 201 of them were determined to be a serious risk of taking their life. And 234 just had the ideation where we were able to work through it and get them the services they need. So we recognize that it is a need in the community. The training is also free to members of the community. If you are interested in learning more information or finding out when the next training is, our emails are up there on the card, or you can reach out to Julie or anyone. They know how to find us.
Julie is also an ASSIST trainer, so her and I both went through earlier on this year. One of the things that I think is very important to talk about is when we look at somebody that is in crisis, the biggest and most important question we can ask them is, do you want to kill yourself? And that is a very hard question for a lot of people to be able to look somebody in the eye and say, do you want to kill yourself? And then what do you do if somebody says yes? So this training is going to help you understand what that looks like and kind of help you navigate that process, because the goal of this training is to help keep somebody safe for now. And then we can get them the resources necessary to make it hopefully a permanent decision to choose life over death. And so, again, this training is very important to the community. It's going to take a lot of time and resources, but we do have the ability to put it on for free. And so, again, our information is up there. I will tell you, at the police department, I have been working there for 12 years, and in the last 2 years, I have responded to more suicides than I care to have had to deal with. In addition to that, prior to Arch starting last month, all supervisors had to handle and look at every welfare check that came into the department. And as a supervisor, we would decide how we were going to handle them, whether we were going to call the person on the phone, whether we were going to just work with Julie or other mental health resources within the community. And so up next is Arch, and they're going to talk about how they've kind of been able to step in and help us navigate that. And so I will turn it over to Nick.
Yeah, this is an exciting new program that just got kicked off. I'll let Nick talk about it, but I believe this is funded by the foundation, right? The hospital foundation funded this entirely to get started. And I think we're going to have a conversation about how it's going to continue on, what you're doing. You were talking about staff, I believe, but anyway. So you've been here for a while, but you got a new role with Assist. So go ahead. Arch, I'm sorry.
So my name is Nick Tornstra. I'm an EMS supervisor at Mary Greeley. I've been there for 6 years. I've been a paramedic for just over 10 years. So, our conversation about Arch started about 2.5 years ago, 2019, I think, right before the pandemic slowed everything down. So Julie and Kinsey and I sat down one December afternoon, had a conversation, because what we were finding responding to calls in the community was that we didn't have a specialized response to certain types of calls. So 911 call comes in and they send either a police officer, paramedic, or fire department, or some combination of the three. And what we were finding was that we weren't really having a good effect on them in the way that we wanted to. So not that we didn't want to, but what was happening was we weren't able to get them the resources they wanted or needed. What happens in EMS is that we come across somebody who's having suicidal thoughts or a mental health crisis, and we have one place to take them, and that's the Mary Greeley ER or some other ER, whether it's down in Des Moines or Story County or somewhere like that. So we really wanted to specialize our response, and so we started talking about creating Arch, and that's where Arch came from. And I'll have a little video. Is this the clicker?
Arch is a community health response team that can respond to a number of needs in the community. It could be for a mental health crisis, it could be for a homeless issue, it could be for a food insecurity issue.
And they're going to be able to intervene in a way that law enforcement or other providers may not be able to, because they have not only the social work component to it, but also the paramedic piece to it.
Arch is looking to provide a more specialized approach to 911 calls that don't fit the criteria for a police or EMS response.
What makes them unique is that they're an immediate response resource in our community, whereas we have some other resources, but it may take them up to an hour to respond to the scene, where the Arch team could respond within 5 to 10 minutes.
The response for Arch begins with the 911 dispatch center, and they'll receive a call, run through their regular line of questioning, and from there determine this is an Arch call, or this still needs a PD or a EMS response or fire department. But if an Arch call is triggered, they'll screen for safety reasons and eliminate any kind of threat to staff, and they'll dispatch a social worker as well as a medical professional, so an EMT or a paramedic.
We're going to assess the situation. We're going to assess what is going on with that individual, determining is this person in a mental health crisis? Are they suffering perhaps from withdrawals from substance use?
figuring out what that person needs.
We see mental health issues and challenges on our campus community, just like in the general community. It does seem to have increased over the last several years, which is why at ISU Police we partnered with Mary Greeley on this initiative. We also have our own mental health advocates on the police department, and we've added robust counseling services and added more staff to our counseling team. We're making sure that we have the adequate resources to serve this community.
We look at it as kind of the old model of where the doctor used to go to people's houses and visit them and take care of their needs, or the home health nurse model where someone would go to a person's house and evaluate their medical needs. So this is really no different than that, but it could be socioeconomic needs, it could be medical needs, it could be mental health needs. So we really feel like this is a great resource for those in our community that could be struggling.
Law enforcement wasn't designed to be a mental health asset, mental health resource. Now our officers have great training and we're there in the interim, and there are cases where law enforcement should respond, but the vast majority of our mental health cases, people are just looking for resources, they need help, and unfortunately our community doesn't have all the help and resources it needs, and so this will just add that one piece that hopefully will make a difference.
I think about what Arch is going to be able to do, to be able to fill in the gaps, to be able to catch some of the folks before it gets to be a crisis level, or where they maybe are calling in suicidal, that we can reach these folks and be able to get them the proper resources. In my mind, it's not just putting a Band-Aid on the problem. This is long-term sustainability.
What we modeled this after was that several other communities are doing a similar thing. So we took a good idea and kind of modeled it for Ames. And one of them was Cahoots, which is based in Oregon, and then the STAR program, which started in Denver about 2 years ago. Cahoots has been around for about 30 plus years, so they've had a good track record of this type of model with a social worker and an EMS provider. And so what we're doing is, so we've launched a pilot program that started on October the 11th. We were funded through the Mary Greeley Foundation. They helped write several grants that we got through Story County Community Foundation, as well as several others. So we were able to purchase that nice Dodge Durango you saw in the video, and we outfitted it with some lighting and some safety features and things like that, and then the shirts, and there's some stickers and pens, things like that. But so really we're launching a 6-month trial. We've been 1 month in, and we're collecting data to really make this a 24/7 response. So right now we run from 10 a.m. to 6 p.m. Monday through Friday. And our goal is to be 24/7, 365 days a year. And we respond to any type of call that doesn't really fit the criteria for police or EMS. And a lot of those fall under the category of like the welfare checks. Our data showed for the first 4 weeks, or actually 3 weeks we were in service, over half of our calls were welfare checks. And really what we're doing is we're knocking on the door. We're making sure people are okay, making contact with them, trying to make a phone call. We don't enter where we're not allowed to, right? We're not breaking doors down or anything like that. We're calling family members to let them know, hey, we checked on them, they're okay. If they let us, we're very careful to ask permission, things like that. We respond to homelessness. So we had a gentleman who was in a bus stop sleeping on a cold day. He actually ended up being transported to the hospital because he was so hypothermic. And so that's the benefit of having the medical person on scene to do that assessment, to determine, hey, this is actually a pretty big need for EMS. But then Lindsay's role is really to establish some planning and resources for them to go to and say, here are some things that we have found have helped in the community. And here's the number you can call, here's how to get a hold of them. We'll actually make the phone call right then and there if we need to. And so we're not really trying to take over for Mobile Crisis or anybody else, because the way that we're dispatched, the way that we respond is through 911. So there's no phone number for you to call to get Arch. Really, it's when people don't know what to do, they pick up the phone, they call 911. They don't often think of those numbers that they've been given in the past. And we'll show up and we'll say, hey, have you tried mobile crisis? Have you tried, the Bridge Home or whatever it might be, and try to get them set up with those resources, and then the next time they won't have to call 911. So really we're trying to clear up those pathways for them and make sure that they know who to call. And the other thing we're trying to do is avoid ER visits. So a lot of times people with suicidal ideation, if they don't have a plan, as a paramedic, one thing we do is we have to bring them in because that's what we're obligated to do. But with a social worker and a paramedic involved, we can have a conversation with them and do some safety planning with them and say, okay, do you have support? Do you have somebody that can stay with you? And we'll check on you and follow up the next day. And that's, and we're very careful with that. We're not, just leaving people who are in crisis. We're really trying to de-escalate the crisis and then get them resources available to them. And I think our first 3 weeks, so 5 days, so 15 days of working, I estimated 12 people avoided an ER visit. So, you think of the cost associated with sitting in an ER room and you tying up a bed for that long, then, it frees it up for the next person. And then the other thing too is it frees up ambulance calls too, because, so just the other day, Arch responded to a call for a mental health crisis in Ames. And because they were on that call, the ambulance that would have been dispatched to that crisis was actually free and responded to a cardiac arrest call in Story City, where a Nevada ambulance was headed. So you think Nevada to Story City is quite a drive. So the crew that was in Ames was able to respond right away instead of having to go to the mental health crisis where they would have taken their time and brought them to the ER. So just things like that are really kind of telling in the first month that this is kind of a good and useful resource. So that's all I had.
Hello, so it's me again, Susan, social worker at Mary Greeley. So the next piece I want to share with you tonight is about our subacute. So this morning, I went out to subacute and I said to Jean is our nurse case manager, Jean, what do you want me to tell everyone? And she said, get the word out about subacute. Spread the word, spread the word, spread the word. It's a service that not a lot of people are necessarily familiar with in the community. So you heard me say I'm not very tech savvy. Here we go. Okay, so I'm not a lot of a slide reader, but I do want to hit some of the highlights. So as you can see, in order to be eligible for subacute, have to be 18 years old or older. Individuals have to have some kind of a diagnosable mental health, behavior, or emotional disorder that meets the DSM criteria. This is all taken care of through our crisis nurse, and I'll get to that, to determine whether or not someone is actually eligible to go to subacute. So it requires, and one of the things Jean said that she really wanted to reiterate tonight is that everything needs to go through the emergency department. This is not something where people can just show up and say, I'm in crisis. If they do, we would direct them to the emergency department, maybe call Arch, help someone to get in there to make sure that they're medically cleared for subacute. Those who will qualify have a high degree of impairment, mental, social, educational, functioning that comes from the psychiatric condition or diagnosis that this individual has. And they are really limited in the skills that they have within that environment at that time. And I'll kind of get to how that's addressed when someone's admitted to subacute and the treatment planning piece of it. And I will get to that. So as you can see up here, there are certain criteria that people have to meet. One of the things that Jean really wanted me to stress to everyone is it's very similar criteria to an inpatient hospitalization in terms of having that mental health condition, mental health crisis. They just do not necessarily meet the criteria to need to be inpatient, to need to be in a unit that is locked. I'll share a story. So great example. So we got a phone call transferred to us from the emergency department, and we had someone within our mental health region, a social worker from different county, And she said, hey, so here's the thing. We have someone that's going to the ED in a different county, and she said, I'm super concerned that they're not going to meet criteria, but they're in crisis, so how can we help? So I was able to kind of talk through, get that information, and get her connected with our crisis nurse who does that. And actually, this was able to work out for this individual. I found it this morning, so that was pretty cool. So yep, we get a lot of phone calls like that too. I'm concerned from other places. This person's been in crisis for months. They're probably going to go to the ED, and they're probably not going to meet that inpatient hospitalization criteria. So how can we help? And this is really where subacute fits in a nutshell. There's a couple things that they do consider. You can see history of violence, self-injurious behavior, if someone is impaired, acute medical needs or inability to perform self-care. We'll get to that. There's some things with diabetes and things with some AccuChecks, and I think that Jean had this included. Or registered sex offender may possibly take them out of being able to be at our subacute. Oh, there it is. So there is the undisclosed address of the home in the Ames community. Yes, and it is beautiful. That is the subacute from the outside. Again, one of the things really that I want to reiterate is that it is very similar to the inpatient unit. They just don't quite need that level of care, don't need that level of supervision. It's least restrictive, a little more homey, all of those things. Okay, referral, sorry. Referral, so your doctor, mental health provider, or the emergency department. I would say most of ours filter through our crisis nurse to determine whether or not that's going to be appropriate for someone to go to subacute. They have a contact that they send. Oh, here it is. Yeah, so there's the living room, as you can see. That's a common area, and then there's the laundry room. That's the kitchen area and the dining room area. And then there's the kind of leisure area, and then that's the back door area. I know that they grill out and they do different things, weather permitting. So a lot of times we get questions. We definitely have different guidelines on the behavioral health unit than they have. They have more room at subacute in a bedroom. So these are things that we would suggest that people would bring with them. Clothing, walking shoes and a coat, hygiene items, personal cell phones, no medications, and then the meds are provided and meals are provided. And I asked Jean about that, and they really want individuals there to be a part of the cooking and helping process, doing things at the home. This is just an example she wanted me to share. It's pretty specific programming. They have the day pretty well structured and pretty well laid out in terms of groups. Laundry. They have kind of, it's really similar to a schedule that we would have up on our inpatient unit. It looks a lot like what we offer on the inpatient unit. There's some rec therapy, snacks, yep, you can see all of that. So one of the things I think, there you go. Contact the nurse case manager, and that is Jean if you have any questions. Jean did want me to tell you guys if you were interested in taking a tour, to call her. She can set that up. So one of the things I need to add too is who pays for this. So we currently have been working towards getting Medicaid certified. That has not happened yet. So we are asking our mental health region, which is 16 counties now, anyone know? I think 16 counties, as well as Jean has worked really hard to get contracts with other counties. So I would say outside of the Central Iowa Community Services region, there are many other regions that have said, yes, we want to do what is best for our individuals. We will pay for your subacute. So we would go to the region and ask them to pay for it if they come from our region. There's just a simple application process to make sure that someone's eligible, then the region pays for the subacute. And then these other regions have also agreed to pay for it too. So that's where it comes from. It's at no cost to the individual. Their region agrees to pay the cost for subacute. And average length of stay is 10 days.
Hello, I'm Shelby Gibson. I'm with the Story County Attorney's Office, and I am contracted to be the Alternatives Care Coordinator for the pre- and post-arrest diversion program. Down button, right? Yep. Okay. So we are a grant-funded pilot program as well, so similar to Arch. We started in 2020, and we were at first funded by the COSAP grant, or the COAP grant. It's been changed now to the Comprehensive Opioid Stimulant and Substance Abuse Program grant. So that just broadened who we can help, and it really is focused on substance abuse. So sorry. So qualifying charges can be diverted if participants meet program requirements, and I am the program coordinator as well as the care coordinator. So our promise is to help people in a disease recovery, into disease recovery. So substance abuse is a mental health diagnosis now under the DSM-5, and so it very much, you cannot talk about mental health without talking about substance use. People don't just start using substances because they're happy and they're okay. It often stems back to something. So that is how I got to be here talking with you today. So our goals are treatment versus incarceration. We do work with individuals coming out of jail, coming out of prison, but our goal is really to limit the amount of police interaction that these individuals are having. It's very costly on our system, especially for the simple misdemeanors that we provide diversion for. We do not help individuals that are violent or have victims. If the victim is an officer, we have to get permission from the officer in order to work with the individual. So we also don't work with sex offenders if the offense has been within the last 10 years. And then obviously victim rights are of utmost importance. So how are referrals made? They can be made in a variety of ways. They can come through the individual themselves. We get referrals from the Ames police officers. We try to get pre-arrest referrals, but we do get a lot of post-arrest or pending charge referrals. That's where the charges sit until the individuals meet program requirements, and then charges are diverted. So it's not just a get out of jail free card here. We are really trying to address substance use and catch individuals very early. We get a lot, I'd say half our referrals are college students, and the other half are people that struggle with lifelong addiction. Oops. Okay. So no matter whether there's pending charges or not, the individual is expected to get a substance abuse evaluation. That's the main program requirement. From there is how we're going to tailor their case management. So if they are mandated treatment, or if that's part of their eval, then I require them to do a specific amount of treatment prior to charges being diverted. If it's their first time through, it's not as much, but I always encourage individuals to do all of their treatment because our rates of recidivism are very low. I'd say 1% for individuals who actually complete treatment and all program requirements. We've only had one individual become rearrested that has completed all program requirements. So that's great. The other thing just to keep in mind is that once an individual goes to jail, even for 6 hours, they are 75% more likely to go to jail again in their lifetime. So that's why we really push for pre-arrest diversion, because we just don't want people in jail that don't need to be in jail. These are low-level crimes, all simple misdemeanors and all nonviolent. So that's me. The other thing that I like to tell people is even if a referral comes in, we've had about 300 referrals since the program started in 2020, which is great. I'd say half of those did not meet program requirements, but I don't just leave them empty-handed. I get them connected with who they need to be connected with. It's really a warm handoff as often as I can. If not, I will make a call with them to where they need to be, because what I found is just sometimes that follow-up isn't there, and it's extremely difficult for individuals to navigate this system. It's very fragmented, and it's very hard to navigate even with education. So I don't know how we really expect individuals who are struggling and really hurting to try to navigate this system alone. So I've talked a lot about this, but really what we're trying to do is move away from the idea of punishing people who need help, right? So incarceration does punish people, and it can remove dangerous people from communities, but incarceration often does not address rehabilitation needs of the person, the family, and the community. So if we get one person into recovery, it's not just one person we're helping their children, we're helping their family members. It's really huge to be able to hear family members say, like, I could sleep again, because they're not worried about this individual overdosing and, hurting themselves. So the other thing that we help with is, I have to catch my breath. We help individuals that are involved with the DHS system. So individuals that have had their children removed and who are struggling with substance use and mental health issues, what I have found is they don't get a lot of support. There's a reason that their children are taken from them, and it's because they need help. They don't need to be punished further by being given barrier after barrier. So I will drive people to appointments. I will make appointments with them. I make sure that these other entities are following up on what they're supposed to be doing, because sometimes they don't. And so having an advocate on their side can really make or break a person's trajectory of life. These are just all the services I offer. It's a lot. I do a lot of networking, so I kind of know everyone, and I think that's good. I think that's just part of it. We walk with individuals. We do not just hand them a card and expect them to meet program requirements. We also pay for evaluation costs. If the person does not have insurance, we can also pay for treatment. I will say, though, we have not had to, because individuals all have met Medicaid or other insurance requirements. And then we can get bus passes through SciRide, monthly bus passes, to help them get to those treatment meetings and things like that. And then I've also helped individuals get phones through a free government phone system. If they break the phone, we have funding to replace the phone one time in the year. So that's a huge thing. Not having a phone is a major barrier that we all take for granted. Not having a phone affects having a job, being able to make your meetings. I mean, we all Zoom from our phones nowadays. So just things like that. I attended the PTAC conference recently, which is the Police Treatment and Community Collaborative. It was a really cool conference, and it was just really neat to hear everyone talk about substance use in relation to the police and treatment and the community all working together, because you can't talk about housing without talking about substance use and mental health. You can't talk about the emergency room and the costs in our county without addressing these issues. So it's all very connected. And I think the sooner we all really realize Story County has these great resources, and if we all work together, we can truly provide a very cohesive continuum of care. Say that 3 times really fast. So yeah, that's everything. My contact information is there. I do have cards available as well, so if anyone wants to chat after, just stop on over.
How are you presenting the alternative school to the student body?
Good question. Our students know that we do have an alternative school coming, and so we have had a few of them come up to us already and ask if what they need to do to enroll or how they'll need to work with that program. I am actually, I just met with Assistant Sup and our superintendent, and we really want to make sure that we do that well, and make sure that we start looking at ways for those students to get in. My biggest thing is I want those students to also have a pathway back to the main campus. So I don't want them to, I hate the word labeled, but I'm going to use it, labeled as an alternative kid for the rest of their life. I always want them to have a pathway back to main campus. And I don't want to call it Gen Education. It is our main campus. We just have satellites, right? And so if that's the best fit for them at that point, great. And if it's not, then we want to get them back on our campus.
Don't leave.
Hopefully that, okay.
So can you comment on the state of mental health at the Ames High School in terms of what the student, what you're seeing and how are they doing?
Our students are struggling. That's where I'm going to get all. Look at you and I start crying. Okay. No, they're, COVID hurt us a lot, but before that, we still had mental health going on. And so every day I talk to kids who are really struggling or hurting and just are having difficulties, whether it's difficulties at home or difficulties with identity, difficulties feeling like they belong. I just try to find ways that I can build a relationship with them. That's really what it's about, right? So, we do have kids who are struggling, and the thing about it is we have kids struggling at every level economically. I have some very wealthy families whose kids are struggling. I have some very non-wealthy families whose kids are struggling, right? It affects everybody. And I think we're seeing that in our school. We're also seeing a complacency of trying to get things finished, refusal of doing things. And that is not, some people are like, what's wrong with these kids? Why are they not doing it? Well, there's something going on there that they're not doing things and they're not following through and they don't care. And so we're seeing it at all levels with all kids, all races and creeds, religion and everything. It's across the board. So so we have hurting kids and we just want to really be able to meet their needs. And our teachers are really working on building relationships and making sure we touch every child in the building.
So I know that the school board just recently created a ad hoc or a committee. It's a mental health committee. There's 3 school board members, on it. They meet separately. Can you just comment on the support you're getting from the school board? I know this is really important to them.
Yeah. The school board is great. They really are behind us and backing us. They really want the success of our students. They want our students healthy. They're fantastic to work with. They're easy to work with. So it's really great when you have a board that cares and that's willing to hear you and see what the needs are and go that extra mile. But outside of that, I've always said, and I'm going a little further, sorry, I've always said that Ames is a very unique community, being that we only have one high school. We don't compete with other high schools such as like Ankeny or anything else like that, what they do. But we have a community that loves on our kids. We have a community that I go out and I ask for supports, and I get it. I talk to different members in our community, and they ask me what we need, and they're willing to help us out. So we have, Ames is just such a supportive and loving community. And then hearing everything else that we have out there tonight, I was like, I want to go to that class. I want to learn that. I want to go to that class. So I'm super excited to learn more and get to know more. But I just really want to thank everybody here because we couldn't do what we do unless we had the support from you guys too. So,
is there anything that we can do practically to help support you and or the kids?
If you have research on therapy dogs, no. I would say, I reach out. I didn't put up, we have a huge mentoring program. We actually work with YSS on that. And so if you want to mentor, we have a lot of kids who need a mentor still, who are waiting for mentors. I also have a need for tutors. So some students, so I'm going to be partnering with Iowa State. Let's talk. But as far as trying to get some other people in there for meeting with kids, mentoring with kids, that positive influence that they have in their life has gone really, really good so far. So if you're interested in mentoring, that would be a way.
So how can they get a hold of you? Nicole.patton@ames.k12.ia.us. No, you can call me at the high school and just ask for me, and I'd be happy to chat with you. And the last ones, these are easy. What does SIPS, SFA, and TAP out mean?
So SIPS is Central Iowa Psychological Services. So that is just a service in Ames, a counseling service. Tap out is if they just need a time, like a break, so they can tap out. Sometimes they'll have a card and they'll show a teacher a card like, hey, I'm going to tap out now. And then they take a 5-minute break and then they come back. So that'd be a tap out, and SFA is our school family. Help me, Jean. I just had a brain fart. student family advocate. She used to be our SFA before she left us to go to the DO, so.
Again, my name is Dr. David Brown. I'm the Behavioral Health State Specialist for Iowa State University Extension. We've been fortunate to receive about $1.5 billion from the USDA for the last 4 years. We have used that money to train 17 of our staff in mental health first aid as instructors, not only for adult, but also youth. Now, our target audience, obviously with USDA funding, is the rural parts of Iowa, to the farmers, the agribusinesses, and those that are supporting our rural populations. And so we don't do too much in Ames, but we do a lot every place else. We also have used that money to do a program called Question, Persuade, Refer, which is a 1 hour, 1.5 hour program on suicide prevention. We have 14 instructors that are able to provide QPR across the state, any place in the state. We also have 2 facilitators who are Spanish speakers. We've offered the program in Spanish. Now, we also are in the process of developing a curriculum to train mental health providers and healthcare providers on the culture of agriculture. Hopefully, we'll have a pilot next spring. So be looking for that. It's called Relationships Can Heal, Knowing Your Farmer Client. So we've been really focused on the ag area. We've done some partnering with the Student Counseling Center, but again, we have 4, and most of our mental health first aid facilitators are in Central Iowa, but again, we have them all across the state. We've also received about $1 million from the Iowa Department of Human Services to do Project Recovery Iowa, and they've allowed us permission to provide mental health first aid now to the workforce in Iowa through the Project Recovery Iowa funds. So again, some of our facilitators involved in that as well. So again, a lot of resources for mental health first aid across the state. Thank you.
Thank you. So my question for you on what are some practical ways that ISU PD interfaces with student health and wellness in terms of your different programs? Can you kind of talk about that? You have lots of data, but just what are some things that you're doing? I know you're doing a lot of things, and you're also going to be rolling out a lot of things coming. Yep. So.
Maybe I can speak to the direct services, and then you can provide other examples. I feel like we talk to Kinsey and April almost every day when we're working with students and supporting them. So we may have a student, and then we may need to figure out what next steps that they need to go to, whether they need to seek hospital care or other resources. And they just do an amazing job on the front end. If a student's starting to have struggle and we might be concerned they're in crisis, they reach out and do a lot of that frontline support, and then make a lot of referrals back and forth, which is really, really nice. So we're so grateful to have you all on campus.
A couple strategies that we've rolled out in this last year, kind of more on the, like Erin was saying, when we think about our broader public health approach, is really kind of leaning into the jargon term is called SBIR. It's Screening, Brief Intervention, Referral to Treatment. So thinking about how can we embed some of those practices within the classroom and kind of across campus. So thinking about how are we increasing our screening efforts, so getting students connected, confidential screening efforts, but then also how we're training some of our staffs and faculty across campus to help in terms of checking in with students on how they're doing and how to help to get them connected to resources. So we actually have a confidential screening tool that all staff faculty can use. So some of them embed it within their classroom as part of like an assignment. Some do it as part of like, their students are coming in to meet with them for office hours. They take it prior to that, allows them an opportunity to kind of check in how things are doing. Students get personalized feedback as part of that screening tool, and also directly connects them to resources based on how they do on that. So that's kind of one piece that we're rolling out. As Dr. Brown was sharing, we've also enhanced our infrastructure on campus connected to education. So we also implement QPR. We have, I don't know exactly off the top of my head, a couple dozen trainers that can help facilitate that. We have a similar program to mental health first aid. It's called Respond. It's a little more focused on college students specifically. It's an 8-hour program. It's virtually the same thing, just a different acronym. So we've also been rolling out and trying to enhance some of our infrastructure connected to that. And then the other piece, what we're really kind of focusing on with our broader needs assessment is thinking about how are we building out our broader infrastructure on campus, really specifically connected to health promotion. So how are we creating sustainable infrastructure, committee structure, capacity around implementing a lot of these pieces? So when we think about, how do we get folks to be able to really embed health and well-being into everything that we do, right? It's how are we embedding that into all of our work, into all of our practices? That takes a big approach, right? So thinking about how are we helping kind of build that structure to be able to do that. And that takes a lot of work to kind of set up. So we're using our needs assessment in our process to really think about what is going to be our best model for doing that. But those are some of the kind of the strategies that we've been working on this last year in terms of helping to embed for our faculty staff to, again, more regularly check in with students. Again, when we think about the early intervention, the connection to resources to prevent folks getting to crisis is really what we're trying to focus on. So how can we do some of that early intervention right away? So those are just a couple of things we've been focusing on. Yeah.
I'm going to put you on the spot, Brian, because we had a meeting a few months ago, and you talked about the fact that we can have all the resources, we can have all these training, but you talked about the fact of the importance of community undergirding that. Can you just talk about that? Because I think that's one thing that we need to talk about, and I appreciate Nicole's comment in terms of how it's her perception that our community is loving on the kids. Well, the point is we want to love on Iowa State students also. What does that look like? Because that is so critical for that. So can you just comment on that just a little bit?
Yeah. I really appreciate that question, Mayor Harrell, because I think it's really important. Erin and I's background is in public health, so we talk a lot about a public health approach. But I think what Julie was saying earlier is that it takes everyone and getting to know that it's all of our responsibility when we talk about creating a culture that's supporting well-being. So we talk about that a lot on campus. How do you actually create a culture that supports well-being? Well, part of that is thinking about and kind of really getting folks to kind of buy into that broader piece that it is all of our role, right? It's not just the police department, it's not just the health center, it's not just mental health services, it's all of us. And actually when we talk with our faculty and staff across campus, we talk about, and from our data, it shows that most people, particularly if they're in some type of crisis or if they're in distress, they're not coming to see me first, they're talking to a friend, significant other, a parent, a family member. That's where the community piece comes in, right? We think about, we all have a role and responsibility in helping to support our broader community. So when we think about those really important efforts of training our community members, because oftentimes they're typically the first ones that are seeing it because they have the trusting relationships with folks. So we talk about these trainings, particularly in rural areas. I can't think of anything more important than that because we know the impact that mental health is having in rural areas. Getting the folks to know and have the skills to be able to connect with somebody and get them to resources is so vital, right? So thinking about that kind of broader community aspect, and then I can't remember who said it earlier too, but when we think about, we talk a lot about mobilizing the community together, right? So thinking about that common agenda where we're all kind of working in that same direction. So I think we all have that similar kind of passion and buy-in of we know that mental health is a crisis. We know that we need to keep working on it. So that's what I love about these opportunities is really bringing the community together to think about how do we really establish that common agenda and think about what's the direction that we want to go and how do we get there together. Part of that is around capacity building and moving the entire community in the same direction and thinking about how we do that. So it's kind of a both and to all those different pieces. But I think the community, it's all of our role. And I think continuing to get that message out and how we really build that culture that, it's all of our responsibility to think about mental health, I think is critical. Yeah.
So can non-Ames residents participate in assist trainings, and then how can they don't ask a question, but how can they get in contact with you to do that?
Sure. Is the person who wrote the question, are they a Story County resident or what county? Dallas County. Yeah, you can participate. You could just email me when we're going to schedule our next one. Actually, I think Sergeant's going to be doing the next one. So, yeah, you can attend those. We do try to provide those for any of the communities that we service, but we offer it. I mean, we're not going to turn anyone away because it's very valuable, and it can potentially save somebody's life. So we do that. Also, I wanted to point out on what the doctor said about QPR is I'm also certified in QPR, and there's specific versions of QPR.
What's QPR?
Question, question, refer, persuade. So there's there's a standard version, there's one designed for schools, there's one designed for veterans. So there's a lot of opportunities there for that. And I'm also certified in youth mental health first aid. So if anybody is looking for that to come into their community, agency, church, whatever, please reach out, get my contact information, or find somebody around here that knows how to get a hold of me, because we absolutely want to be a benefit to your community and provide that education.
Nick, can you come up just a second? I want you to you made a presentation to Communities Excellence Board. Just give some ideas on the number of calls you've gotten even in the last 3 weeks. You mentioned that the number of diversions you had, but just a little bit of a snapshot. I mean, this is a phenomenal program that is undertaken, and I mean, that seemed very excited, but I'm very excited about it because it's something that we really need in this community, and we'll be talking about it, and it's going to take an investment to keep it going on, but just share how much you've already been used, that's the wrong term, how much your services have been needed, not used, right?
Yeah, so like I said, we started on the 11th of October, and up till today, we're at 49 calls. So that's, in 25 days, 20 days. And so they range from, we've had calls where somebody's texted their out-of-state parent and said, I'm feeling suicidal. And they call 911 and they say, can you check on my son or daughter? So we go knock on the door, and he's or she, they are confused a little bit why we're there, and we kind of introduce ourselves and we'll say, hey, we're checking on you. We had a call from your parent, guardian, and they say, well, I'm just needing some counseling. I'm struggling. I don't know where to start with counseling. So we start making phone calls, and it was that particular one. It was kind of late in the evening, so we make a few phone calls. We talk to Dad on the phone, and we ended up making a safety plan and said, we'll check in with you tomorrow morning. We knew Dad was on the way down from where he was, so he was going to be there sometime in the night. So it was fairly soon after we were there. He didn't need to go to the ER at that point. He wasn't actively doing anything to harm himself, just having thoughts, and he needed help getting some counseling started. And so we just did that for him. We followed up the next day. He said, I'm doing better. My dad's here. We talked to Dad, made some phone calls, and he's on his way to counseling. Another call we went on was for an individual sleeping in front of the police department, and I think actually you had some involvement with that one later on, but we made a phone call for him to get an intake questionnaire with the Bridge Home. So we had a contact there. We called her over. She actually met us right there out on the street. We walked over to the church where they were serving lunch, and she sat down with this individual and got him an appointment to meet with the Bridge Home. Now, my understanding is he didn't make it to his appointment, but so we'll have more conversations with him, as time goes on. But we're really just trying to be like a pivot for people who are in crisis and get them pointed in the right direction. I mentioned the person sleeping at the bus stop and how that actually needed an ambulance intervention. So we did a quick assessment and found out that, he was intoxicated and he needed an ambulance to come and take him to the hospital. But again, no fire department was needed to come out. And the police department didn't need to respond. We called for an ambulance. I assisted with them in the back, to try to get him situated and transported. So, there's tons of stories. I'll repeat the question was, what happens when an Ames resident calls 988? And to my knowledge, so I believe that it goes to, do you want to take it? Yeah.
That's a great question because it was just implemented. So if somebody calls 988, that call is routed to Foundation 2. It's the call center in Cedar Rapids, Iowa that contracts all those calls. But because the person calling lives or is calling from Story County, that would be routed to our mobile crisis team. And so there would be an assessment over the phone. And basically they try to do some de-escalation skills in that and get some basic demographic information and see if you need that face-to-face interaction. And then they would dispatch our team where we would come out in plain clothes, plain car, and do that mental health evaluation and determine that. But I will say there's a little caveat with calling 988 because as you can imagine, the state now handles all those calls, and before they were just contracted with specific counties. I think they had 14 or 17 contracts. Now they have all of them. So if they are busy and somebody calls 988 and they cannot get through, it's not that they can't get through, they'll be bounced to a second agency that will try to kind of do those same things. But if they're busy, then it bounces back to the National Suicide Hotline. And so those two other entities I just described, they don't know how to dispatch us because we are contracted with Foundation 2. So it might be a little bit of a longer process. They are trying to work out those kinks, but Foundation 2 did mention that last month 98% of those calls were handled by the 988 Foundation 2 staff out of Cedar Rapids. So just that small percentage was bounced to another line. Historically, October is just really a very busy month for a lot of reasons, and especially with children, we find so. Like I mentioned, if you call 988 and you don't have to live in Story County or we service 18 counties in Iowa. So you do not have to live in any of them. You just have to be physically standing in one of them. Oftentimes we find that people will drive over a county line just to receive our service. So they'll get triaged over the phone, and depending on where they're at, if it's determined that they need that face-to-face assessment, our team will be dispatched out. We can spend 4 minutes with someone, 4 hours, 10 hours. We spent 8 hours on Saturday with somebody up in northern Iowa. We also never send a bill. You will never see a bill from us. We are graciously funded through the region, and so that's really important because I think finances, especially now with inflation, a lot of people are really struggling with that. And then the really kind of interesting and cool thing that we like to talk about is after the end of that call, within 24 hours, our case management team is going to follow up. And their goal is to really connect that individual with the resources in their community. And they're going to stay with that individual. They're going to meet with them face to face. They're going to transport them to appointments. They're going to help get them medication. If they need pet food, if they need clothing, they will do whatever they can to get those services implemented. A lot of time it's a matter of finding funding for utilities or if they need funding for therapy. And so I think we obviously don't know all the resources, but we know a lot of people in the community that we all reach out to and say, hey, do you know somebody with this or that? So we do whatever we can to help them. It is a short-term case management. So once we get them connected with the long-term provider in their community, we'll make sure that they have that rapport, they have solid transportation, and then I get excited. I get so passionate about this. We'll step back, but we just want to make sure that they're stabilized. The other thing that we offer for our program in all 18 counties is community-based crisis stabilization services. And that is when somebody calls 988 or the crisis line and the team goes out and it's determined that they are in a crisis and need immediate stabilization, but perhaps they won't meet criteria when they go to the ER. So the goal of that program, it's a 5-day program where every day a case manager goes out for 2 hours to the person, whether it's at their home or a private place. We telehealth in either a psychiatrist, medication provider, and daily therapy. And so basically in those 5 days, we work on building a stabilization plan. What are you struggling with right now? Okay, so we're going to come up with a plan. So say it's suicidal ideation, and we're going to set goals and we're going to set objectives, and we're going to meet with them every day for that time, and we're going to go over things, and we're going to educate them, and we're going to teach them coping strategies. They'll also have that mental health professional therapeutic component to that. And so the goal is within those 5 days that those issues have decreased or stabilized, if you will. So that's really important. We also never send a bill for that. That's also graciously funded by the region. So, and that is a fairly new program that we implemented through the state. I'm sure most of you are familiar with like actual physical buildings that have the crisis stabilization. Ours is just designed a bit differently. We go to the clients. We service all ages. So yes, children, we do, of course, want their parents involved in that because it does take the entire family, educating them in that. So that is a benefit that we do offer to the community as well.
And Susan, I just had a quick question on subacute. How many people can you handle? And length of stay, and maybe a success story if you have. Can you come up here and share about that?
Subacute, there is 8 beds. Again, I had mentioned they're sort of in pods. There's 2 rooms and then there's the bathroom, so they can have up to 8 individuals staying there at a time. Average length of stay is 10 days. Sometimes we do find that individuals need to stay a little bit longer, although we would say that 10 days would be the anticipated length of stay. So we would tell individuals to plan on that. Success stories. So that is, I'm gonna do my best to think of one. Part of what's difficult for me is when we talk about HIPAA, so I don't know who's at subacute. And then the staff don't necessarily know who's on our unit. But I will tell you that they do really great work at subacute. I can just share some things that they have done. Helped individuals get an apartment, help individuals get to another state to be with family to help further stabilize. I mean, they just do so many wonderful things at subacute for individuals.
And this was just a snapshot of a few of the resources that we have in Story County and Ames. We just try to grab something from the school district, from the hospital, a new program, some training opportunities, but I'm not going to name all of them, but YSS does an amazing job in this community. NAMI does National Association for Mental Illness, does a phenomenal job. And there's just more, the more I delve into this topic, we have an amazing amount of resources in our county available to us. We just a lot of times don't know where to go. How do we access them? And one of the things that I just want to reinforce what Nick was talking about, you're kind of like a traffic cop too. If someone has a need, you know where a resource is, you'll point them to get someone to it. You're sharing about one of the homeless persons, you're trying to help them get housing at the Bridge Home. There's going to be other opportunities for housing as well too, and obviously homelessness is going to be more and more important as we get into the winter months, and so that's going to be an important aspect as well too. So I just don't want you to think that this is the only thing that we have available. This is just scratching the surface essentially. And you heard about things last month, if you came to the suicide conversation. We have a moving forward group from Gilbert that's looking at trying to roll that out in further areas. YSS talked about what they were doing also. So it's just a matter of, we're very fortunate, and so we're just trying to get the word out, what is available. So, and just as a by example, in September, there was a mental health expo held at the ISU Memorial Union. And I was amazed at how many booths, I think there was like between 20 and 30 booths of people that provide, or groups that provide mental health services from on campus, off campus, it was a wide range. So with that, thank you for coming, and we're skipping December. It's kind of hard to schedule something during the holidays. And also we're trying to schedule it so we can offer it so when Iowa State students are back in school, are back in town. So that's why the next one will not be until January 31st. That one will be at the library, at the Ames Library Auditorium, the Firewall T. Brown, on resiliency. And we have 6 minutes left. Can you give us, Julie, can you come up here? I'm going to put you on the spot. Talk about, one of the things you've mentioned in our conversation is the lack of resiliency and how it contributes to mental health. Can you just talk about what you're observing and why that's the next topic on our agenda?
Well, resiliency is obviously important for all of us. One of the things that I think that a lot of providers, educators, a lot of folks are seeing, especially within our youth, is this lack of resiliency. And so I think it's important for just basic knowledge of how do we take care of ourselves? What does that look like? Coping skills, just various different things that we all can do to be more resilient. Kind of how this came about, one of our officers, she and I became resiliency instructors specifically for our officers. And so all of our officers went through officer resiliency actually this last year. And after that, we kind of took it out into the community. We've had various different folks that have asked for that. So we tailored it to these specific folks. And all of us really need to work on being resilient, right? So again, it's things that we all know, but just great reminders. Again, meditation, just how do we look at certain situations? How are we responding to those situations? How do we maybe need to change the way that we think so we can respond in a more positive way, and to be able to deal with all of the, unfortunately, some of those negative things that we're all going to deal with in our lives, and how can we deal with those in a more healthy way? And so we are wanting to have that conversation for adults, but again, for children as well, because we are seeing a lot of our kiddos that are really struggling with how do we cope when maybe even when we fail, just really seeing a lot of some struggles. So hoping that we can have a good discussion about that, and then ways that maybe there's some, again, free education to bring resiliency into various organizations or schools.
If you are interested in mental health first aid training, assist training, any other questions or comments, good or bad, the good ones go to me, the bad ones go to Julie. No, just kidding. No. Again, julie.saxton@cityofames.org, and then we haven't got a mental health first aid training class scheduled yet, or an assist training class scheduled for a group yet. But if you are interested, email Julie. We'll put you on a list. We will not sell your email, and we'll make sure that you are notified when one does come up. So with that, thank you very much for coming out, and please give a round of applause to all of our presenters.